Abdominal part of esophagus and stomach. Introduction. Only about 1 cm of esophagus lies in the abdominal cavity. It acquires great importance as it is a site of portosystemic anastomoses. Stomach is the chief organ in the epigastric and left hypochondriac regions. Its lesser curvature bears the brunt of all fluids which are too hot or too cold, including the insults by the alcoholic beverages. Esophagus and stomach. Dissection. Identify the stomach and trace it towards the abdominal part of esophagus. Clean this part of esophagus. Note various parts of stomach, e.g. cardiac and fundus, body, and pyloric parts. Trace the right and left gastric arteries along the lesser curvature and right and left gastroepiploic arteries along the greater curvature. Tie 2 ligatures each at the lowest part of esophagus and the pylorus. Remove the stomach by cutting between 2 upper ligatures through the esophagus, left gastric artery, gastrophrenic ligament, and by cutting the pylorus between the lower 2 ligatures. Free the stomach from the adherent peritoneum if any and put it in a tray for further dissection. Abdominal part of esophagus. 1. The abdominal part of the esophagus is only about 1.25 cm long. 2. It enters the abdomen through the esophageal opening of the diaphragm situated at the level of vertebra T10, slightly to the left of the median plane. It continues with the cardiac end of stomach. The esophageal opening also transmits the anterior and posterior gastric nerves, the esophageal branches of the left gastric artery and the accompanying veins. These veins of esophagus drain partly into portal and partly into systemic circulation. Veins accompanying left gastric vein drain into portal vein. Others drain into hemiazygos, in thoracic cavity, and continue into vena azygos and superior vena cava. So it is a site of portosystemic anastomoses. The esophagus runs downwards and to the left in front of the left crus of the diaphragm and of the inferior surface of the left lobe of the liver, and ends by opening into the cardiac end of the stomach at the level of vertebra T11, about 2.5 cm to the left of the median plane. Its right border is continuous with the lesser curvature of the stomach, but the left border is separated from the fundus of the stomach by the cardiac notch. Peritoneum covers the esophagus only anteriorly, and on the left side 2 anterior gastric nerve contains mainly the left vagal fibers, and the posterior gastric nerve mainly the right vagal fibers. Each gastric nerve is represented by 1 or 2 trunks and combines a few sympathetic fibers from the greater splanchnic nerve. Histology. Mucous mucophorane epithelial lining is stratified squamous non-keratinized in nature. Lamina propria consists of loose connective tissue with papillae. Muscularis mucosae is distinct in lower part and formed by longitudinal muscle fibers. Submucosa contains mucus secreting esophageal glands. Muscularis externa is composed of striated muscle in upper third, mixed type in middle third, and smooth muscles in lower third. Its outer layer comprises of longitudinal coat and inner layer comprises of circular coat of muscle fibers. Adventitia is the connective tissue with capillaries. The lower end of the esophagus is one of the important sites for portosystemic anastomoses. In portal hypertension, the anastomosis opens and forms venous dilatations called esophageal varices. Their rupture causes severe and dangerous hematmesis. Normally the lower end of the esophagus remains closed and dilates only during the passage of food. However, due to neuromuscular incoordination it may fail to dilate, leading to difficulty in passage of food or dysphagia. The condition is known as achalonsiacardia. Marked dilatation of the esophagus may occur due to collection of food in it, Fig 19.5. The lower end of the esophagus is also prone to inflammation or ulceration by regurgitation of acid from the stomach. It is the commonest site of esophageal carcinoma. Next site is the middle third of esophagus. Hiatal hernia occurring through the esophageal opening and can be rolling or paraesophageal and sliding, Figs 19.6a and b. Barrett's esophagus, squamous epithelium of lower esophagus may be replaced by columnar epithelium in certain clinical conditions. The abnormal type of epithelium present in esophagus is referred as Barrett's epithelium. Trachea esophageal fistula. At times the separation of trachea and esophagus may not be complete. Proximal segment ends in a blind pouch and distal segment communicates with trachea. The lumen of the esophagus may be abnormally narrowed due to improper canalization. The lumen of esophagus may not be canalized at all, leading to esophageal stenosis. The stomach is also called the gaster or venter, from which we have the adjective gastric applied to structures related to the organ. Definition: the stomach is a muscular bag forming the widest and most distensible part of the digestive tube. It is connected above to the lower end of the esophagus, and below to the duodenum. It acts as a reservoir of food and helps in digestion of carbohydrates, proteins, and fats. Location: the stomach lies obliquely in the upper and left part of the abdomen, occupying the epigastric, umbilical, and left hypochondriac regions. Most of it lies under cover of the left costal margin and the ribs. Shape and position: the shape of the stomach depends upon the degree of its distension and that of the surrounding viscera, e.g. the colon. When empty, the stomach is somewhat J-shaped, vertical; when partially distended, it becomes pyriform in shape. In obese persons, it is more horizontal. The shape of the stomach can be studied in the living by radiographic examination after giving a barium meal. Size and capacity: the stomach is a very distensible organ. It is about 25 centimeters long, and the mean capacity is 1 ounce, 30 m1, at birth, 1 liter, 1000 ml, at puberty, and 1.5 to 2 liters or more in adults. External features: the stomach has 2 orifices or openings, 2 curvatures or borders, and 2 surfaces. 2 orifices. The cardiac orifice is joined by the lower end of the esophagus. It lies behind the left 7th costal cartilage cm from its junction with the sternum, at the level of vertebra T11. There is physiological evidence of sphincteric action at this site, but a sphincter cannot be demonstrated anatomically. The pyloric orifice opens into the duodenum. In an empty stomach and in the supine position, it lies 1.2 centimeters to the right of median plane, at the level of lower border of vertebra L1 or transpyloric plane. Its position is indicated on the surface of the stomach, A, by a circular groove, pyloric constriction, i.e. sthenic. Sometime it may hypopospheric, thin and lorigi, hypersthenic pylorus, produced by the underlying pyloric sphincter or pylorus. Pylorus equals gate guard, which feels like a large firm nodule. B, by the prepyloric vein which lies in front of the constriction. 2 curvatures. The lesser curvature is concave and forms the right border of the stomach. It provides attachment to the lesser omentum. The most dependent part of the curvature is marked by the angular notch or incisura ungularis. The greater curvature is convex and forms the left border of the stomach. It provides attachment to the greater omentum, the gastrosplenic ligament and the gastrophrenic ligament. At its upper end, the greater curvature presents the cardiac notch which separates it from the esophagus. 2 surfaces. The anterior o anterosuperior surface faces forwards and upwards. The posterior or postero-inferior surface faces backwards and downwards. 2 ports subdivided into 4. The stomach is divided into 2 parts, I cardiac. 2. Pyloric, by a line drawn downwards and to the left from the incisura ungularis. The larger, cardiac part is further subdivided into the fundus and body, and the smaller, pyloric part is subdivided into the pyloric antrum and pyloric canal. 1 pyloric antrum. 2 The fundus of the stomach is the upper convex dome-shaped part situated above a horizontal line drawn at the level of the cardiac orifice. It is commonly distend with gas, which is seen clearly in radiographic examination under the left dome of the diaphragm. 3 The body of the stomach lies between the fundus and the pyloric antrum. It can be distended enormously along the greater curvature. The gastric glands distributed in the fundus and body of stomach contain all 3 types of secretory cells, namely, A. the mucus cells, B. the chief, peptic, or zymogenic cells which secrete the digestive enzymes, C. the parietal or oxyntic cells which secrete HCl. Pyloric part. 1 The pyloric antrum is separated from the pyloric canal by an inconstant sulcus, Sulcus intermedius present on the greater curvature. It is about 7.5 centimeters long. The pyloric glands are richest in mucus cells. 2. The pyloric canal is about 2.5 centimeters long. It is narrow and tubular. At its right end it terminates at the pylorus. 3. Relations of stomach. 4. Peritoneal relations. 5. The stomach is lined by peritoneum on both its surfaces. At the lesser curvature the layers of peritoneum lining the anterior and posterior surfaces meet and become continuous with the lesser omentum. 6. Along the greater part of the greater curvature the two layers meet to form the greater omentum. 7. Near the fundus the two layers meet to form the gastrosplenic ligament. 8. Near the cardiac end the peritoneum on the posterior surface is reflected onto the diaphragm as the gastroepiploic ligament. Cranial to this ligament a small part of the posterior surface of the stomach is in direct contact with the diaphragm, left cruce. This is the bait area of the stomach. The greater and lesser curvatures along the peritoneal reflections are also bare. 9. Visceral relations. 10. The anterior surface of the stomach is related to the liver, the diaphragm, transverse colon, and the anterior abdominal wall. The areas of the stomach related to these structures are shown in Fig 19.8. The diaphragm separates the stomach from the left pleura, the pericardium, and the 6th to 9th ribs. The costal cartilages are separated from the stomach by the transversus abdominis. Gastric nerves and vessels ramify deep to the peritoneum. 11. The space between left costal margin and lower edge of left lung on stomach is known as Troub's space. Normally, on percussion there is resonant note over this space, but in splenomegaly or pleural effusion, a dull note is felt at this site. 12. The posterior surface of the stomach is related to structures forming the stomach bed, which are separated from the stomach by the cavity of the lesser sac. These structures are, 1. Diaphragm. 2. Left kidney. 3. Left suprarenal gland. 4. Pancreas. 5. Transverse mesocolon. 6. Splenic flexure of the colon. A splenic artery. Sometimes the spleen is also included in the stomach bed, but it is separated from the stomach by the cavity of the greater SAE, and not of the lesser sac. Gastric nerves and vessels ramify deep to the peritoneum. Blood supply. The stomach is supplied along the lesser curvature by the left gastric artery, a branch of the celiac trunk. The right gastric artery, a branch of the proper hepatic artery. 1. Along the greater curvature it is supplied by the right gastroepiploic artery, a branch of the gastroduodenal. 2. The left gastroepiploic artery, a branch of the splenic. 3. Fundus is supplied by 5 to 7 short gastric arteries, which are also branches of the splenic artery. The veins of the stomach drain into the portal, superior mesenteric and splenic veins. Right and left gastric drain in the portal vein. Right gastroepiploic ends in superior mesenteric vein, while left gastroepiploic and short gastric veins terminate in splenic vein. Lymphatic drainage. The stomach can be divided into 4 lymphatic territories as shown in. The drainage of these areas is as follows. Area, A, of Fig 19.11, i.e. upper part of left 1/3 drains into the pancreaticosplenic nodes lying along the splenic artery, i.e. on the back of the stomach. Lymph vessels from these nodes travel along the splenic artery to reach the coeliac nodes. Area, B, i.e. right 2/3 drains into the left gastric nodes lying along the artery of the same name. These nodes also drain the abdominal part of the esophagus. Lymph from these nodes drains into the coeliac nodes. Area, C, i.e. lower part of left 1/3 drains into the right gastroepiploic nodes that lie along the artery of the same name. Lymph vessels arising in these nodes drain into the subpyloric nodes which lie in the angle between the first and second parts of the duodenum. From here the lymph is drained further into the hepatic nodes that lie along the hepatic artery, and finally into the coeliac nodes. Lymph from area, D, i.e. pyloric part drains in different directions into the pyloric, hepatic, and left gastric nodes, and passes from all these nodes to the coeliac nodes. Note that lymph from all areas of the stomach ultimately reaches the coeliac nodes. From here it passes through the intestinal lymph trunk to reach the cisterna chyli. Nerve supply. The stomach is supplied by sympathetic and parasympathetic nerves. The sympathetic nerves are derived from thoracic 6 to 10 segments of the spinal cord, via the greater splanchnic nerves, and coeliac and hepatic plexuses. They travel along the arteries supplying the stomach. These nerves are, A. Vasomotor, B. Motor to the pyloric sphincter, but inhibitory to the rest of the gastric musculature. C. The chief pathway for pain sensations from the stomach. The parasympathetic nerves are derived from the vagi, through the esophageal plexus and gastric nerves. The anterior gastric nerve, made up of 1 or 2 trunks, contains mainly the left vagal fibers, and the posterior gastric nerve, again made up of 1 to 2 trunks, contains mainly the right vagal fibers. The anterior gastric nerve divides into a number of gastric branches for the anterior surface of the fundus and body of the stomach. B. 2 pyloric branches, one for the pyloric antrum and another for the pylorus. The posterior gastric nerve divided into a smaller gastric branches for the posterior surface of the fundus, the body, and the pyloric antrum. B. Larger coeliac branches for the coeliac plexus. Parasympathetic nerves are motor and secretomotor to the stomach. Their stimulation causes increased motility of the stomach and secretion of gastric juice rich in pepsin and HCl. These are inhibitory to the pyloric sphincter. Interior of stomach. Dissection. Open the stomach along the greater curvature and examine the mucous membrane with a hand lens. Then strip the mucous membrane from one part and expose the internal muscle coat. Dissect the muscle coat, e.g. outer longitudinal, middle circular, and inner oblique muscle fibers. Feel thickened pyloric sphincter. Incise the beginning of duodenum and examine the duodenal and pyloric aspects of the pyloric sphincter. Features. The stomach has to be opened to see its internal structure. 1. The mucosa of an empty stomach is thrown into folds termed as gastric rugae. The rugae are longitudinal along the lesser curvature and are irregular elsewhere. The rugae are flattened in a distended stomach. On the mucosal surface there are numerous small depressions that can be seen with a hand lens. These are the gastric pits. The gastric glands open into these pits. The part of the lumen of the stomach that lies along the lesser curvature, and has longitudinal rugae, is called the Gasfreur canal or Magens-Frasse. This canal allows rapid passage of swallowed liquids along the lesser curvature directly to the lower part before it spreads to the other part of stomach, Fig 19.13. Thus lesser curvature bears maximum insult of the swallowed liquids, which makes it vulnerable to peptic ulcer. So, beware of your drinks. 2. Submucosa of stomach is made of connective tissue, arterioles, and nerve plexus. 3. Muscle coat is arranged as under. A. Longitudinal fibers are most superficial, mainly along the curvatures. B. Inner circular fibers encircle the body and are thickened at pylorus to form pyloric sphincter, Fig 19.14. A. The deepest layer consists of oblique fibers which loop over the cardiac notch. Some fibers spread in the fundus and body of stomach. Rest form a well-developed ridge on each side of the lesser curvature. These fibers on contraction form gastric canal for the passage of fluids. 4. Serous coat consists of the peritoneal covering. Functions of stomach. L. The stomach acts primarily as a reservoir of food. It also acts as a mixer of food. 2. By its peristaltic movements it softens and mixes the end food with the gastric juice. The gastric glands produce the gastric juice which contains enzymes that play an important role in digestion of food. 4. The gastric glands also produce hydrochloric acid which destroys many organisms present in food and drink. 5. The lining cells of the stomach produce abundant mucus which protects the gastric mucosa against the corrosive action of hydrochloric acid. 6. Some substances like alcohol, water, salt, and few drugs are absorbed in the stomach. 7. Stomach produces the intrinsic factor of Castle which helps in the absorption of vitamin B12. Gastric pain is felt in the epigastrium because the stomach is supplied from segments T6 to T9 of the spinal cord, which also supply the upper part of the abdominal wall. Pain is produced either by spasm of muscle, or by overdistension. Ulcer pain is attributed to local spasm due to irritation. Peptic ulcer can occur in the sites of pepsin and hydrochloric acid, namely the stomach, first part of duodenum, lower end of esophagus and Meckel's diverticulum. It is common in blood group O. Gastric ulcer occurs typically along the lesser curvature. This is possibly due to the following peculiarities of lesser curvature. A. It is homologous with the gastric trough of ruminants. B. Mucosa is not freely movable over the muscular coat. C. The epithelium is comparatively thin. D. Blood supply is less abundant and there are fewer anastomoses. E. Nerve supply is more abundant, with large ganglia. F. Because of the gastric canal, it receives most of the insult from irritating drinks. G. Being shorter in length, the wave of contraction stays longer at a particular point, viz., the standing wave of incisura. H. pylori infection is also an important causative factor. Gastric ulcers are common in people who are always in hurry, mostly worry about incidents and eat spicy curry. Gastric ulcer is notoriously resistant to healing and persists for years together, causing great degree of morbidity. To promote healing, the irritating effect of HCI can be minimized by antacids, partial gastrectomy, or vagotomy. Gastric carcinoma is common and occurs along the greater curvature. On this account, the lymphatic drainage of stomach assumes importance. Metastasis can occur through the thoracic duct to the left supraclavicular lymph node, Troisier sign. These lymph nodes are called as signal nodes. It is common in blood group A. The pyloric obstruction can be congenital or acquired. It causes visible peristalsis in the epigastrium, and vomiting after meals. Hypochondriac stomach is more prone for gastric ulcer, while hypersthenic stomach is prone for duodenal ulcer. Histology of stomach. At the cardiac end of stomach, the stratified epithelium of esophagus or upfly changes to simple columnar epithelium of stomach. Cardiac end, mucous membrane, the epithelium is simple columnar with small tubular glands. Lower half of the gland is secretory and upper half is the conducting part. Muscularis mucosae consists of smooth muscle fibers. Submucosa, it consists of loose connective tissue with Meissner's plexus. Muscularis extens, it is made of outer longitudinal and inner circular layer including the myenteric plexus of nerves or Auerbach's plexus. Serosum, it is lined by single layer of squamous cells. Fundus and body of stomach. Mucous membrane, it contains tall simple tubular gastric glands. Upper 1/3 is conducting, while lower 2/3 is secretory. The various cell types seen in the gland are chief or zymogenic, oxyntic, or parietal and mucous neck cells, Fig 19.15. Muscularis mucosae and submucosa are same. Muscularis externa, it contains an additional innermost oblique coat of muscle libres. Serosa is same as of cardiac end. Pyloric part, mucous membrane, there are pyloric glands which consist of basal 1/3 as mucous secretory component and upper 2/3 as conducting part. Muscularis mucosae is made of 2 layers of fibers. Submucosa is same as in the cardiac end. Muscularis mucosae externa comprises thick layer of circular fibers forming the pyloric sphincter. Serosa is same as of cardiac end. Development, esophagus, the posterior part of foregut forms the esophagus. It is very small in the beginning, but it lengthens due to descent of lungs and heart. The muscle of upper 1/3 is striated, middle 1/3, mixed, and lower 1/3 smooth. Nerve supply to upper 2/3 is from vagus and to lower 1/3 is from autonomic plexus. Epithelium of esophagus is endodermal and rest of the layers are from splanchnic mesoderm. Stomach, the caudal part of foregut shows a fusiform dilatation with anterior and posterior borders and left and right surfaces. This is the stomach. It rotates 90 degrees clockwise, so that left surface faces anteriorly. Even the original posterior border of stomach grows faster, forming the greater curvature. The stomach also rotates along antero-posterior axis, so that distal or pyloric part moves to right and proximal or cardiac part moves to left side. The 90 degrees rotation of stomach along the vertical axis pulls the dorsal mesogastrium to the left side, creating the lessor sae or omental bursa. Spleen appears as mesodermal condensation in the left leaf of dorsal mesogastrium. Mnemonics: esophagus, ureter, and duodenum. Abdominal part of esophagus is the site of portosystemic anastomoses. Some veins drain into hemiazygos vena azyga superior vena cava. Other veins drain into esophageal veins, left gastric vein, portal vein. Stomach comprises 2 orifices, cardiac and pyloric, 2 curvatures, lesser and greater 2 parts, cardiac and pyloric, cardiac part, fundus and body, pyloric part, pyloric antrum, pyloric canal, and pylorus. Anterior gastric nerve contains left vagal fibers and posterior gastric nerve contains right vagal fibers. Lesser curvature is the anterior border and greater curvature is the posterior border. Left and right gastric arteries run along lesser curvature. Left and right gastroepiploic arteries lie along greater curvature. Pylorus is identified by prepyloric vein. Stomach bed is separated from the stomach by lesser sac. The gastric ulcer is common in people who worry, hurry and eat hot curries. Gastric ulcer commonly occurs along lesser curvature. Gastric cancer mostly occurs along greater curvature. Lymph from cancer: thoracic ducts left, supraclavicular node. It is called Virchow's node. This sign is called Troisier sign.